Good afternoon to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined this platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Ash Sujit. Sir is MBBS diplomat of National Board in OBS and Gynecology, Fellowship in Minimal Access Surgery, Diploma in Gynecology Endoscopy from uh, Kennel University, Germany. Senior Consultant in Gynecology and Ops Department at PD Hinduja Hospital, Mumbai. Now, with the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is update in endometriosis. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, sir.
Endometriosis. So, to begin with, endometriosis itself is a challenge even today. And it's now that we are spending money and diverting our thoughts towards finding out what endometriosis is, the different pathways, and how we can affect them to provide better outcomes. So, endometriosis, as we all know, is endometrial tissue which grows at different places other than the uterus lining. The most common areas that we are aware of are the ovaries, the PODs, and the uterosacrals, but it can be at other places such as the bladder, the abdominal cavity or the pelvic cavity, the vagina, even the nasal cavity, or we have scar endometriosis. What we understand is endometriosis is basically a disease of the lining and the action of hormones that it is produced on the linings because of the ovaries. And it has very little to do with the uterus alone. We all know that there are different modalities of managing endometriosis, but medical management per se forms the cornerstone when you need to achieve a treatment for it. Obviously, you can always think of hysterectomy, but then as we discussed that it is not per se related to just the uterus. It is the hormones and the impact of the ovaries. Therefore, medical management becomes more important. In certain scenarios of endometriosis, like the adenomyosis, where there is lining which grows in the muscle layer of the uterus, and that is why that leads to bulky uterus, menorrhagia, and severe dysmenorrhea. In that situation, you might require a hysterectomy as a final resort. But in all the other scenarios of endometriosis, medically managing the case would be a better option. We know of the treatments that are currently available, that is NSAIDs, which help us to provide symptomatic relief from the pain, dysmenorrhea, and it's often the first line of treatment. Apart from that, we can obviously opt for hormonal treatment, which can be either a short term along with an NSAID, like a contraceptive pill or injections or patches, or it can be given for a long term period also, like an implant or an IUD, which makes the cycles lesser in the flow and also reduces the period pain. Apart from that, we have progestins, which are synthetic progesterones that stop the periods during the course of its treatment. It can be again available as IUDs or skin implants or injectable shots or just like normal pills. This is the current treatment plan that we all opt for, which help us to reduce endometrial tissue. It shrinks it, and therefore it reduces the inflammation and the damage caused by endometriosis, thus providing the treatment outcome. There are a few other things that we all know about that aromatase inhibitors can also be used along with the hormonal treatment, which lowers the effect of estrogen and thus it reduces the symptoms. GnRH analogs that completely shut down the menstrual cycle and therefore it acts like a pseudomenopause. And this is something which can be preferred before or after surgery so as to shrink the areas before the surgery and to prevent recurrence for a long period after the surgery. Whatever said and done, medical treatments are temporary and they work only for the period of time that they are given for. And once the treatment is discontinued, there are definite chances that the inflammation or the pathology can come back. And this is what you also need to explain it to the patient, that endometriosis is not completely curable. You might tackle one part of it, but obviously, till the time the menstrual cycle continues, then the endometriosis lesions can re-grow again, or it can grow at different places also. The current scenario is also approaching a holistic way and therefore working on the lifestyle and even a dietary changes, such as having more antioxidants in a diet, consuming fiber rich food, avoiding smoking, getting into proper physical activity, and getting proper sleep and reducing stress. All these things are also supposed to benefit a person with endometriosis. You can opt for a surgery. Conservative surgery is the plan when you need to do along with medical treatment whenever you want to preserve the uterus and you want to maintain fertility. This is done in cases of infertility which is specifically targeted towards patients with endometriosis. So supposedly you have an endometriotic cyst with some adhesions because of endometriosis. In such cases, you tackle the ovarian cyst, you do the cystectomy, you clear out the pathology, and you remove the adhesions. And the idea is to make sure that you restore the tubo-ovarian anatomy in the best way possible, which can give better fertility outcomes, rather than doing something like a major surgery, and you rather damage the ovary and the entire anatomy. So the idea is to perform minimal surgeries, but to restore the tubo-ovarian anatomy at the best. Also, one thing which I usually advise is to get EMH done before and maybe even after surgery so that you know that whatever surgery you have done, that has not damaged the ovary to a larger extent. And you can also discuss fertility and if there's any other boost or any other procedures that are required so as to make sure that the patient conceives better. So, with all these things, now we understand that it's a challenge to diagnose as well as treat endometriosis in general, which we all know during our recent practices also. So, newer advances are made so as to understand the disease better in terms of etiology of the disease and also how it spreads, to diagnose it earlier so that we can not just rely on laparoscopy as a modality of investigation and staging, to understand the pain pathway so that we reduce the pain which is caused because of endometriosis, and eventually to provide better treatment options so that the patient gets symptomatically better and also the treatment is something which lasts for a longer period. So now coming to certain investigations thing, imaging things basically. Laparoscopy, as we all know, has been the gold standard in diagnosing and staging endometriosis. But there are other things which can be used as an imaging modality, which basically checks on the mechanical properties of the tissue, such as the stiffness and the viscosity, which can be tested by ultrasound or magnetic resonance imaging. So when we do by ultrasound, it's called ultrasound shear wave elastography, which is USSWE, or magnetic resonance elastography, which is MRE. So these are the two things which we can do even nowadays as added to our practice, which will improve us to, which will help us to diagnose endometriosis faster. And the other thing is just adding an analog during PET scan, which is gallium 68 labeled somatostatin analog, which can help us identify deep tissue endometriosis better. Whereas if anyone is refusing any of these invasive things, you can obviously think of a CT scan, which can also help us to diagnose. The recent thing that we are aiming is to have AI based tools combined with imaging study, which will give us a better idea of the disease progression and the tissue involvement in endometriosis. But what we need to know is that USSWE, or that ultrasound shear wave elastography, and MRE, that is magnetic resonance elastography, can be something which is better. MRE is something which is more sensitive and holds enormous promise when we have to have a detailed characterization of the mechanical properties of endometriotic lesions, thus helping us as surgeons to know where the disease is, how much is the spread, what kind of a lesion it is, whether it's a hard, solid lesion or whether it's a soft cystic lesion. And this can also help us whenever we are planning for a surgery. MRE also offers advantages over SWE is that it can even detect something as small as 1 centimeter cube volume area, and therefore it can detect at a very early stage. And therefore, it is something which is very sensitive as we talk about, and it is more useful as a complementing along with the sonography. And therefore, you can decide on doing a investigation or any treatment faster, and therefore it will also work on a long-term basis for the patient. The other things that we can use as imaging modalities or detection modalities rather is estrogen responsive genes such as growth regulator estrogen receptor binding 1, that is GREB1. RNA-based studies are also into practices currently, so we are doing certain studies which will help us detect that. There are certain research which are based on disruptions in the synchronization of the ovarian cycle and the endometrial lining. Studies which are based on ovarian function via estrogen suppressive treatments through elevated expressions of estrogen receptor beta, that is ESR2. And most of the researchers currently, whatever are actually in practices, are targeted towards the inflammatory markers like IL-6 and cytokines. So that is where most of the research is targeted, because the main pathology or the main idea is whenever you have endometriosis, there is inflammation which happens at the tissues, and that is what leads to pain and adhesions. So, this is where the target is. The link between inflammation and endometriosis is established, and increased inflammatory cytokines have been detected in even the peritoneal fluid, which is also the scenario which is seen in rheumatoid arthritis also. Therefore, we understand that there is an established link between increase in cytokines, especially interleukin 6, and prolonged time to pregnancy also. So, studies in mouse models have also demonstrated that steady increase in inflammation with age is major contributor to age-related follicle depletion, but also more studies are required to explore this factor when you have to consider endometriosis associated infertility. And whenever you consider infertility in patients with endometriosis, it can be multifactorial. So you need to know about other issues also which are complicating the fertility outcome. Genomic studies are available where you do single nucleotide polymorphisms or calcitonin gene related peptide receptor gene studies, which are correlating endometriosis with other GI symptoms such as migraine and asthma along with it. Endometriosis pain and spread, like we discussed, is majorly inflammatory in process, and that is why inflammatory markers can help. There are various analgesic targeting different pain pathways which are under research, where we have a drug also called frelogistant, an antibody also receptor which are directed against interleukin 8, which are available and which are also in the early research phase of drug trials. Based upon all these observations, initial studies evaluated the efficacy of targeting tumor necrosis alpha as a potential treatment for endometriosis also. When you have a recombinant human TNF alpha binding protein in a rat model of endometriosis, and we did a lot of studies in the baboon model also. Though the reduction is not very significant, but this also will be something which has to be looked forward in the future, that this can be one way or the other helpful in detecting or rather in the treatment of symptomatic endometriosis. It is a pro-inflammatory cytokine, and it has been documented in peritoneal fluid also and serum of women with endometriosis. But we have to find out whether it can be helpful or whether we can do something which is targeted towards TNF alpha and therefore reduce the induction of proteases and inflammatory mediators and reduce the adhesion associated with endometriosis. There is also MIF, which is elevated in peritoneal fluid circulation and peritoneal macrophages from ruminant endometriosis, and it's expressed in active or early stage on endometriosis and in random ectopic endometriosis, which can be seen along with endometriosis. These things are induced by estrogen. The MIF is induced by estrogen. Therefore, whenever you have to target MIF expression, it's always also targeted on hormone related with estrogen. Initial studies of ISO as a therapeutic agent for endometriosis treatment are encouraging, as MIF antagonism reduces lesion burden in mouse models, therefore demonstrating its efficacy. Furthermore, inhibition effect of MIF antagonism occurs independently of reproductive cyclical, which means estrogen levels in action and therefore permit continuation of reproductive cycles with relieving disease burden. So what we see here is that even if you're giving some antagonism treatment for MIF, the cyclical length of estrogen is not affected. Therefore, we can continue it for a longer period, thus not causing any hormonal imbalance. These are still under studies and warrant evaluation in human model, but animal models are being done so as to reduce the impact of endometriosis on the pain pathway and the inflammation pathway. MIF have been also shown to stimulate prostaglandin production, and prostaglandin has been considered to be one of the pro-inflammatory actions. Therefore, if you think of managing MIF, you will also think of reducing the inflammation, and therefore the things become more better to manage in cases of endometriosis, where you need to reduce the adhesions, where you reduce the need to reduce the inflammation which is caused around the tubo-ovarian aspect, so as to reduce the effect of fertility also. In vitro support role of PGE in mechanism conducive in endometriosis establishment and survival has shown that the prostanoid receptors E2 and E4 have been inhibiting cellular adhesion, invasion, and growth and survival of human endometriotic tissue in vitro level pair. So what basically it is that whenever you have to target MIF and PGE2 at the specific receptors, it will help us to at least reduce the endometriotic damage which is being caused in vivo also. Eventually, we have gut microbiota brain axis also, which has been now been targeted, reducing the pain neurological axis in endometriosis related symptoms. And this opens newer opportunities for us to relieve endometriotic related symptoms. Gluten rich diet, probiotics, anti inflammatory food items have always been pondered upon, and now it has been considered also for reducing the symptoms of endometriosis. In the newer thing, what we have more is repurposed cancer drugs, which are in the phase 2 trial of endometriosis treatment. Dydrogesterone 30 mg, which is an oral progesterone, which is being considered, and now also in the practice whenever you need to reduce endometriosis. Cannabis is being considered as a treatment to alleviate pain, which is associated with endometriosis. Also, AI along with MR imaging is something which is now the future, where we have to detect endometriosis faster and adenomyosis faster so that the diagnosis is effective, and then we can start with the treatment. So AI guided even robotic surgeries are something which are now being looked forward so that you can approach a next level of treatment in cases of endometriosis when you're planning for a surgery. Whatever the discussion is, we still know that it's still a challenge whenever you need to manage endometriosis, and the treatment will vary, and even the surgery plan also can vary. And there are multiple factors which involve whenever you come into discussing endometriosis regarding which stage of endometriosis is, who is the doctor who's performing the surgery, or even deciding the treatment. What medical treatment are you planning before, during, and even after surgery? So therefore, the lesions will be coming again and again if you're not tackling it well, or if you're not talking to the patient properly and explaining the patients regarding the sequelae of the diseases. Therefore, whenever you're managing endometriosis, you need to know that this treatment protocol or the management protocol has to be individualized for the patient. And as I always say, that endometriosis is a Pandora's box. There are too many things which are still unclear about it, and too many research is still pending, and the treatment modality is still in a very nascent stage. So there is a lot of future in endometriosis if we detect more pain pathways, and if we detect better imaging studies, and we come up with better treatment plans. Thank you.
Thank you so much, sir. We do have questions. Would you like to take that up?
Sure. Thank you.
Thank you, sir. It's been a wonderful conversation. So the first question from our audience is, How effective are non-invasive diagnosis tool compared to laparoscopy in detecting endometriosis?
So in the current scenario, we obviously have laparoscopy as the best modality. But if done under a guidance of a proper ultrasound machine, and if the sonologist is aware of the scenarios and aware of the conditions, then it becomes a little better to pick up imaging modalities and endometriosis on an earliest level. But I would still say that endometriosis is your clinical diagnosis and your ability to think about endometriosis, because even if you leave the fact that if a woman comes to you with pain and if you tell that there's nothing, it's psychological, the sonography doesn't show anything, you have to be pro endometriotic in your thought so that you can detect it earlier and you can provide some treatment rather than letting a woman suffer with endometriosis. So, if you read the statistics, also it takes at least 7 to 10 years for a woman to get a diagnosis of endometriosis. So, if you know that if as a doctor, I'm more inclined towards thinking about endometriosis, then even with a clinical judgment, you can detect it. But obviously, imaging studies are not very good. Then you have to rely on laparoscopy. It depends on how well you're good with your ultrasound person, how well you're good with your clinical studies, so as to give a vis-a-vis of what is better than what.
Thank you, sir. There's another question. What are the updated criteria for diagnosing endometriosis in adolescent patients?
We are still following the age-old criteria of going in laparoscopically and the American School of Endometriosis diagnosis. So there's nothing which is much changed. Adolescent criteria also remains more or less the same when you think about it, with certain changes. So again, endometriosis in adolescent, when you come across, it's still a rare situation. It's not very common. It can happen, but the idea is whenever you have an endometriosis in adolescent age group, you have to think about any uterine anomaly. You have to think about any other tubal pathology, because in such scenarios you have to see where has the pathology originated from. When you look into endometriosis, we majorly look or we consider endometriotic to be a disease of the reproductive age group. So adolescence is slightly early. So you have to figure about all the other inflammatory reasons also. So like we discussed, all the recent advances that it says that endometriosis is somewhere related to inflammation also. So you have to rule out other inflammatory diseases in such scenarios. You have to rule out any uh, structural pathology in the reproductive tract also, so that it helps you to give a better treatment modality or management modality for that adolescent girl, rather than just relying again on laparoscopy and identifying and staging the disease. So that is what my take home message for an adolescent endometriosis would be.
So, there's one last question. Are there any new complementary therapies that have shown efficacy in managing endometriosis?
So we discussed about complementary therapy. So yes, the gut microbiome thing or probiotics are something which are being now targeted. So basically, probiotics will act along with your diet, which is your anti-inflammatory diet, and those are being targeted, which will be complementary along with the treatment, along with the painkillers, or along with the hormonal thing that you're thinking about. This is somewhere where the target is. I have not enlisted that part because it's still in a very early research phase, but you are targeting Proteus bacteria, which is there, which we must have studied about in our microbiology lecture. So Proteus is being targeted, and we are sending it as a carrier along with a probiotic, which will be improving your gut microbiome, which will improve your antioxidant absorption, and it will lead to a better holistic outcome, which I had mentioned in one of the slides, that your holistic outcome, which is targeting your anti-inflammatory, your sleep, your reduction of smoking, all these things will combine together, which will be complementing along with your acupunctures and all these things which are there in the market, which people are still opting for acupunctures or needle therapies and other random therapies which are there, which medically is still not proven, but if it works for my patient, then I'm always in for those things if it's working for the patient. So these things are the future, which can be helpful when you think about a complementary therapy along with a hormonal or a symptomatic therapy. Thank you.
Thank you so much, sir, for answering all our questions. Before concluding, sir, any take-home message from your end?
Again, the take home message remains the same. Think about endometriosis as a line of differential so that you can identify it or at least treat it. And whenever you're managing endometriosis nowadays, there are a lot of myths around it. So always be very fixed about whatever you want to say. Endometriosis is not something which can be cured completely. So this is something which you need to tell your patient and always give various options which are available along with whatever the outcomes at different age groups which are necessary that you can make the patient as symptom free as possible. Thank you.
Thank you so much, sir, for joining us today. With your permission, I would like to conclude today's session. Thank you.
Thank you. Thank you so much.